Hello. In this section, I will talk about complex regional pain syndrome. Now, it's rather a mysterious chronic pain syndrome. Number of times we don't know any inciting event which has caused the pain. The pain is disproportionate to the inciting event. Pain is there even after resolution of the inciting event. Now, pain does not follow a single nerve territory or dermatome. It is a vague kind of pain. Then management is also very difficult. Some patient respond to one type of therapy, some patient respond to other type of therapy. So again, we would rather describe it as a mysterious pain syndrome, chronic pain syndrome. In this section, I would discuss the pathophysiology, the proposed pathophysiology. How do we make a diagnosis? How do we proceed with the treatment? What are the different treatment modalities which are available? And we would discuss with a case scenario, right? So I have a patient who came to me. She is a 54 years old female who presented to the orthopedic clinic to evaluate the sharp burning pain in her left lower leg. She stated that pain started 8 months after an open reduction and internal fixation surgery of her left tibial plateau and has progressively got worsened. So patient was, let's say, referred to our pain clinic. The patient is 54 years old, female. Now we have to pick up the things which are important. Then she has a sharp burning pain in her lower limb. The pain started after a orthopedic surgery and progressively getting worsened. Now we will see what are the predisposing factors which could take us towards the diagnosis of complex regional pain syndrome. One thing I want to say, it's a mysterious pain syndrome, but maximum cases are reported in the extremities, upper or lower extremities. So she is a perimenopausal patient. She is female. She has a vague pain and the pain is followed after some inciting, some surgery. So let us see whether it comes in the criteria of complex regional pain syndrome diagnosis or not, and how we will proceed with the management. So what is the definition of complex regional pain syndrome? What is the definition? Now, complex regional pain syndrome describes an array of painful conditions that are characterized by a continuing, spontaneous or evoked. It could be would be a spontaneous pain, or maybe by touch or temperature, anything can evoke the pain. That is continuing regional pain that is seeming disproportionate in time or degree to the usual course of any known trauma or other lesion. The pain is regional, though a specific nerve territory may not be there, and usually has a distal predominance, and it may be accompanied with the sensory, motor, sudomotor, vasomotor and trophic findings. And pain has an unusual course. It could be progressive in the due period of time. So syndromes show a variable progression over time, and sometimes it's resolute as well. So it is something which cannot be predicted, whether there would be a progression or resolution with management, whatever. So this is how a complex regional pain syndrome is diagnosed. So pain is continuing, seeming disproportionate to the inciting event, that is any surgery or any trauma. It is regional but not specific to a particular nerve territory or dermatome, and it may be accompanied with sensory, motor, sudomotor and vasomotor or skin changes. Okay. Now, what were the older nomenclature? All those nomenclature has been brought into this complex regional pain syndrome. We heard about so many nomenclatures like your reflex sympathetic atrophy or your, let's say, algodystrophy. All are the older names of this nomenclatures of the complex regional pain syndrome. So what are the other nomenclature? Like we had, it was earlier called, some variety of the complex regional pain syndrome was called reflex sympathetic dystrophy, right? Then it was called algodystrophy, then causalgia. Some causalgia was one of the earlier nomenclature. Then sudic atrophy. Then your transient osteopenia, because we would discuss osteopenia may be associated with this disorder. So transient osteopenia, osteopenia. And sometimes the complex regional pain syndrome develops after a history of myocardial ischemia, or let's say stroke. And then the nomenclature that was given to that was shoulder hand syndrome. So upper extremity involvement following stroke and MI, following stroke or MI. It was called shoulder hand syndrome, shoulder hand syndrome, right? So all these older nomenclatures has been brought into a single category of complex regional pain syndrome, and it is a single category, but sometimes it is divided into two types depending upon whether we have a history of inciting event or not, depending upon whether we have involvement of the autonomic nervous system or not. So two subtypes has been recognized but not very rigidly followed worldwide. We have complex regional pain syndrome 1, type 1, which was formerly called reflex sympathetic dystrophy. That was, this category is under C. It's a very big different type of pain which has been categorized under complex regional pain syndrome. So one of the variety which is now categorized under complex regional pain syndrome, that is reflex sympathetic dystrophy, has been given the nomenclature type 1, right? This corresponds to patient with your CRPS without evidence of peripheral nerve injury and comprises of approximately 90% of the clinical presentation. So there is no evidence of nerve injury. So we have nothing, nothing we are able to pinpoint as the cause of the pain. Then we have type 2, which was previously called causalgia, refers to the case with a peripheral nerve injury in which the peripheral nerve injury is present. So type 1, no known peripheral nerve injury, no evidence of peripheral nerve injury, right? And in type 2, there is an evidence of peripheral nerve injury. Type 1 was earlier called reflex sympathetic dystrophy, and type 2 was earlier called causalgia. Okay, then we have warm and cold subtypes of CRPS. That differentiation depends upon the how, when we touch the skin of the area involved, has the temperature, right? So warm CRPS distinguished by increased skin temperature at the onset of symptoms, further suggesting it is inflammatory type. I'll just discuss the pathogenesis, and it has a very unclear, vague pathogenesis: inflammatory mediators, autoimmune mediators, then your let's say genetic factors, a lot of things involved in it. Then cold CRPS has a decreased skin temperature, right? So hot and cold type, some investigator has let's say divided CRPS into. Now let's talk about its complex pathogenesis. Now pathogenesis is unknown, but a lot of proposed hypotheses. So pathogenesis is unknown. Pathogenesis unknown. So what are the proposed mechanism of pathogenesis? Proposed mechanism. Now proposed mechanism involves both peripheral and central nervous system. So both involvement of peripheral and central nervous system. So the whole process may involve the classic inflammation because there are the increase of pro-inflammatory factors in the blood. Then neurogenic inflammation, right? Then maladaptive changes to the pain perception. We call it central sensitization. So even the pain is a very small, just we touch the patient and patient complains of a very complaints of pain, right? So maladaptive changes in pain perception. So we have maladaptive changes in pain perception, right? And then we have somatosensory processing. Change in somatosensory processing. Now, these are some of the proposed mechanism involving peripheral and central nervous system, but some autoimmune factors, some genetic factors has also been implicated, which I'm going to discuss. So, peripheral inflammation, classic peripheral inflammation. So, how was it suggested that it's a possibility that classic peripheral inflammation has resulted in this CRPS? So, the pro-inflammatory factors, peripheral inflammation, involvement due to pro-inflammatory cytokines increased in the blood. Pro-inflammatory cytokines are there more in blood. So interleukin 1 increases, then interleukin 2, then tumor necrosis factor alpha, interleukin 6, all are increased in the blood. Then some neuropeptides are also produced. Neuropeptides. So substance P, then neuropeptide Y, then calcitonin related neuropeptide, calcitonin gene related neuropeptide, and that's why in the treatment they have proposed the use of calcitonin related peptide. All has been implicated. Now, apart from this, the peripheral increase in the pro-inflammatory and neuropeptides, some autoimmune component has also been described. So, autoimmune component has also been described, right? Why the autoimmune implication? Because some important, let's say, antigens in the blood has been increased in patient with the diagnosis of CRPS. So, there is a presence of anti-nuclear antibody and IgG autoantibodies against surface antigen on autonomic neurons has been seen. So, presence of anti-nuclear antibodies and IgG autoantibodies against the surface neurons of autonomic neurons, surface antigen of autonomic neurons has been seen. So, autoimmune implication has also been suggested. Now, apart from that, catecholamine hypersensitivity, the release of the catecholamine in the blood and patient has increased hypersensitivity to that. So, catecholamine hypersensitivity has been seen in these patients. They are most sensitive to the catecholamine. In a different patient, same amount of catecholamine will not produce that effect which in these patients are producing. So, catecholamine hypersensitivity. So, I talked about the maladaptive changes to the pain perception. We call it central sensitization. So, what is the central sensitization? Now, this is another possible explanation for pain and allodynia in CRPS. Allodynia, that patient has a different pain perception with a very small amount of stimulus, increased pain perception to unimportant stimulus, increased activity in nociceptive afferent due to peripheral noxious stimuli, tissue damage or nerve injury leads to increased synaptic transmission at somatosensory neurons in dorsal horn of the spinal cord. Now, the central cortical reorganization in sensory and motor regions of brain and the evidence of glial activation may lead to persistent activity of primary nociceptive neurons to cause central sensitization. So, initially, when the pain mediators were released, the dorsal horn or the somatosensory neurons in the dorsal horn, they have an increased synaptic transmission to these pain, let's say, of these pain stimulus, and this makes the cortical reorganization in sensory and motor area of the brain, and which causes a maladaptive, let's say, a sensation of the same pain stimulus. Even when the pain stimulus has been removed, patient still feels pain because of this cortical reorganization which happened during the initial pain stimulus. So, an initial pain stimulus, if not properly managed, can lead to central sensitization. And a lot of, let's say, in acute pain management, if we are not doing a very good acute pain management post-surgery, post-trauma, then this central sensitization may develop. This is a maladaptive change of pain stimulus due to cortical reorganization of the sensory and the motor neurons, right? Even in the absence of stimulus, patient may complain of pain due to this central sensitization. Okay. Then we have some genetic factors have been implicated. The patient who have shown to let's say diagnosed with CRPS, they have some genetic genes which has been seen in these patients. So what are the genes which have been implicated? The HLA DQ1 for CRPS type 1 has been very much implicated, and the second gene HLA DR3. So just keep in mind that there are some genetic, let's say genetic involvement in CRPS as well. Now what is the epidemiology? What kind of patient may present with more with CRPS? Female more predisposed. The female to male is 2:1 to 4:1. It has been reported, the incidence, and it is higher in post or perimenopausal patient, higher in post menopausal patient. So our patient which we discussed, she was 53 years old, like perimenopausal or postmenopausal, it could be anything. She was 54 years old and she is a female patient, so she has two predisposing factor for CRPS. Now the third predisposing factor is inciting event. Now, most common inciting event is fracture or crush injury or sprain or any kind of surgery. So, she had a history of surgery. Okay. So, there can be an inciting event leading to the CRPS. So, inciting event. So, most common inciting event is any history of any fracture, crush injuries, sprains not properly managed, and surgery. Right. Now, distribution of the inciting events may be varied according to the subtype. Like it is more commonly the inciting event is associated with the carpal tunnel syndrome. The carpal tunnel syndrome is one of the common inciting event associated with the CRPS type 2. That is carpal tunnel syndrome. There is some peripheral nerve injury which can be neurogenic cause, which can be seen, and it may develop in CRPS, that even after management the patient complains of pain. So it depends upon the type of injury as well. Okay, so inciting events may be some surgery, some fracture, some sprain, some, let's say, crush injury, anything. So what does this suggest? This suggests that when these things happen, we have to do a very good pain management to prevent this CRPS to develop, especially in patients who are genetically more predisposed, right? Okay, we'll talk about management more further. So what is the clinical feature? What are the clinical features? Of course, it's a pain syndrome. So there would be a pain, but this is not a pain which is just a pain. This pain is associated with sensory changes, motor changes, sudomotor changes, skin trophic changes, right? So we have pain, we have sensory changes, we have motor involvement, we have autonomic symptoms, and we have trophic changes in affected limb. So we have trophic changes in affected limb, right? And generally these follows 4 to 6 weeks most commonly, though the time span is not proven, but most commonly in most of the studies 4 to 6 weeks after inciting event, right? And more commonly it is seen in upper limb compared to lower limb. So more commonly seen in upper limb compared to lower limb. Okay, so what kind of pain may be associated with the CRPS? Now pain is very vague pain. Now pain can be it is vague but most prominent and debilitating symptom of CRPS. So most prominent and debilitating feature. It could be a burning sensation, it could be a stinging sensation, or it could be a tearing sensation, it could be a deep pain, it could be felt deep to the level of bone. Then it can be continuous, it and undulating. Then it can increase at night, so worse at night. And any movement of the limb may exacerbate the pain. So exacerbated by limb movements. It can also be exacerbated by just a small contact, or let's say stress. Even patient having some stress, the pain can come back. So this pain is a kind of a very most prominent symptom of CRPS, and it could be burning, it could be stinging, it could be tearing. It's a deep pain. The patient complains continuous, undulating, worse at night, and can be precipitated even by a light touch or a stress, right? Anything can precipitate it. So what are the sensory abnormalities which may be seen with the pain? Now, sensory abnormalities which has led to this pain is hyperalgesia. Patient, just a touching would cause huge pain in the patient. That touching would not cause any pain in any other person. So hyperalgesia, there is a hyperalgesia. Then there is allodynia, that is even in the absence of any symptom, let's say any stimulus, the pain can be there, or pain perception can be different. Then hyperesthesia, that is abnormal sensations in the limb. Then could be, this is usually in the limbs, and usually in the distal limbs. And the sensory symptoms of, especially of hypothesia, can be of stocking and gloves pattern, can be of stocking and glove pattern. Okay, now this is the pain and sensory abnormalities most commonly associated.